Dear colleagues, you're all welcome. First of all, many thanks to the organizing committee for this kind invitation. I will talk about cystic lesions of the pancreas from a radiologist's perspective. Here you can see the outline of my talk. Let me start with a brief introduction. As we all know, parallel to the advances in imaging technology, now the detection of incidental PCLs has increased significantly. Rate of incidental PCL detection has been reported to be up to 50% when MRI is used. Fortunately, most of these lesions are benign, but unfortunately, there is marked overlap in the imaging findings. It is hard to differentiate between some subtypes. Differential diagnosis is critical because management and prognosis differ significantly among different subtypes. We may use ultrasound, CT, MR, and MRCP for detection and diagnosis of PCLs, but among those, the best modality is MR and MRCP. MRI is superior to CT due to its high soft tissue resolution. What does it stand for? Soft tissue resolution helps us to evaluate the septal and nodular structures inside the cyst. Ductal communication is best shown with MRCP, and lack of X-ray exposure is an important advantage of MRI for patients that are put on follow-up. I won't go into detail, but optimal MRI technique is a must. If MRI cannot be performed for some reason, there may be a contraindication, then radiologists should use curved multiplanar reformat images to find out the presence or absence of ductal communication. What are the expectations from the radiologist that should be included in our report during PCL evaluation? First of all, we need to mention about the size, location of the lesion, and evaluate the morphology. Presence or absence of communication with the pancreatic duct is very critical. Afterwards, we should mention if there are septal structures, nodular structures, or papillary septopapillary structures inside the cyst. If we think the cyst is mucinous subtype, then we have to indicate the presence or absence of worrisome features and high-risk stigmata according to the guidelines, whichever guideline you use. Interval growth should be mentioned. At the end of our reports, we try to make a recommendation like routine follow-up, close follow-up, or histopathological correlation is needed. There are different classifications of PCLs. We are using this one mostly on radiology. Most of them are non-neoplastic, and there are two main subtypes, one with epithelium and one without epithelium. I will start with the non-neoplastic cysts and show you some imaging examples. Lymphoepithelial cysts are very rare non-neoplastic lesions. They are mostly multiloculated. One will see septa inside. There will be no connection with the pancreatic duct, which helps us to differentiate from IPMNs, but they don't have specific imaging features like most other subtypes of cysts, so it is not possible to differentiate them from pseudocysts or MCNs just by imaging. Here, the main pitfall is, normally in radiology, if some lesion is restricting diffusion, it means there is increased cellularity there, and it is mostly on the neoplastic side. But lymphoepithelial cysts will restrict diffusion due to their keratin content. Let me show you a histopathologically confirmed case. There is a cystic lesion with septa in the head of the pancreas. After contrast administration, there is no enhancing nodularity. But please note that there is intense diffusion restriction. It's bright on diffusion, but this is not due to cellularity. This is due to keratin. The other subtype of non-neoplastic cysts are SCOPes, squamous cysts of the pancreatic ducts. They are again rare lesions. Actually, they were defined many years ago in pathology literature, but imaging findings still are not very well documented. We are lagging, I think, pathology. It is in the form of case reports and case series. They are mostly unilocular. We don't expect to see septa or nodularity in these cystic lesions, and there will be no ductal communication. Let me show you a couple of cases. In this patient, there are more than one cyst subtype. The first one on the coronal T2 weighted image is a branch duct IPMN with high-risk stigmata because it has nodularity inside. There is main ductal dilatation. Actually, this patient was shown to have mixed type IPMN after surgery. And we have observed a scomoid cyst of the pancreas at the body portion. Please note that this is very simple looking, benign lesion, no contrast enhancement, simple fluid inside, and no septa or nodularity. This is again another patient with more than one cyst subtype. These were all detected by on-site pathology radiology correlation from one of our studies. It was a thesis study. This patient has a side branch IPMN in the uncinate process. There was a PDAC, not very well seen here, I know, but there are some cysts around the PDAC. They were retention cysts. There was another side branch IPMN and main duct dilatation because the patient had mixed type IPMN. Plus, there was a very benign looking unilocular cystic lesion at the body portion of the pancreas, which came out to be scope after on-site correlation. Let me mention about simple mucinous cysts. They are defined pathologically as cysts with mucinous epithelium without ovarian stroma, different from the MCN. Again, the imaging findings are not well documented yet. They don't have unique imaging features. Different from scopes, they may have septa inside. They are usually solitary, and we won't see any ductal communication. In the differential diagnosis, one should consider MCNs, IPMNs, and scopes because they have similar imaging features. Let me show you a case. In an outside center, a cystic lesion in the pancreatic body portion was detected by MRI. You can see it as typical T2 bright cystic intensity. There was no contrast enhancement. There at that center, EUS was performed and FNAB showed atypical cells. So she was referred to our center for this, for distal pancreatectomy. Here you can see the distal pancreatectomy specimen, which revealed SMC with high-grade dysplasia. So as Dr. Atsai mentioned, SMCs don't seem to be that simple. Another patient, CT was performed for this old lady for acute cholecystitis with stones. An incidental cystic lesion was detected at the head of the pancreas. MRI was performed, which revealed no specific imaging finding. This was a cyst with a few septa inside with no ductal communication. So this is not an IPMN. It was removed, which came out to be SMC, again with high-grade dysplasia. Retention cysts are defined as cystic dilatations of the pancreatic duct secondary to an etiology that causes intraluminal obstruction. This could be benign, such as a stone, mucin, or this could be PDAC, actually, pancreatic cancer. I should emphasize at that point that I will show an interesting case. They may be the preceding finding of PDAC, and newly developing retention cysts on imaging studies should be cautiously reviewed and mentioned in the report. So follow-up is needed in this case. The differential diagnosis will be branch duct IPMN. They look like each other. Let me show you a typical case. There is a PDAC in the neck portion of the pancreas. It is hypovascular on hypoenhancing on post-contrast study. And on the T2 weighted image, please note that around the PDAC lesion, there are cysts adjacent to each other. They look like a pearl necklace. These are typical for retention cysts, which were confirmed by on-site, again, pathology radiology correlation. You can see the islands of PDAC and retention cysts adjacent to the mass. Formerly, I was diagnosing them as branch duct IPMNs, but these are different entities. A very interesting patient. Some pancreatic cysts were detected during imaging of a patient, an old lady. follow-up was recommended. On the first year of follow-up, radiologists reported that everything is stable. So routine follow-up is enough. But there was something changing there. Please concentrate on the tail portion of the pancreas. There were newly appearing retention cysts, actually, and secondary ductal dilatations. And in the second year follow-up, now these are much more prominent, and now there is a PDAC at the distal part of the body of the pancreas. So I believe the PDAC was there, but it was not visible to our eye, to imaging. So it's important to be cautious about retention cysts. Before switching on to neoplastic cysts, I will mention about pseudocysts briefly. They are the most common PCL subtypes. Here, the clinical scenario is important. There will be a history of pancreatitis or trauma. They may be uni or multiloculated. There may be septa inside, but these septa will never enhance with contrast, different from other neoplastic lesions. There may be debris inside looking like nodularities, but they won't enhance with contrast. In the differential diagnosis, we should consider branch duct IPMNs and MCNs. In the CT image, on the axial and coronary format images, you can see a typical pseudocyst that has developed after acute pancreatitis. And this is a pseudocyst of another patient. You can see the classical cystic bright signal on T2. There are some debris inside, but they will never enhance with contrast. Sometimes pseudocysts may have ductal communication. The neoplastic cystic lesions are also termed as cystic pancreatic neoplasias. They have two main subtypes, the non-mucinous and mucinous subtypes. I will start with non-mucinous type. SCN, serocystic neoplasias, are typically grandmother lesions, so demographics help us during differential diagnosis of cystic lesions. They are most commonly seen in females and at old age. They may be in any location. There is a well-known growth rate that we should be aware of as radiologists during reporting. I believe the most important distinguishing feature of SCNs are outer lobulated contour. There are three main morphologic subtypes, the most common being microcystic pattern. In the microcystic SCN, one will see a lot of tiny cystic locules with septa in between, and these septa will enhance after contrast administration. In some of the patients, these septa unite towards the center to form the typical T2 dark stellate scar appearance, and it may be calcified in 1/3 of the patients. In the macrocystic variant, please note that the outer contours are lobulated. There are less cystic locules, less number, and larger cystic locules. It will closely mimic MCN. What are the differences? The outer contour of MCN will be smooth. The outer contour of SCN will be lobulated. And also after contrast material administration, one will see contrast enhancement in the wall of the MCN, different from SCN. These minor differences help us in the differential, and there will be no ductal communication. There is also the mixed subtype where one will see macros and micros at the same time. Grandmother lesion, there is a cystic lesion at the tail of the pancreas. Please note the outer contours are very lobulated. There are many septa inside. This looks like a microcystic one, but there are some macros in the periphery, and here you can see the typical T2 dark central stellate scar. And there is no wall enhancement after contrast administration. This is an oligocystic or macrocystic variant where you can see less cystic locules and they are larger, bright on T2. Please note the outer contours are very lobulated, different from MCN. And there is a very, very dark central stellate scar on T2. Dark on T2, very dark on T2 means calcification, which was further confirmed with CT. CT sometimes help us to confirm calcifications. This is a very interesting case. This is one of the most important imaging pitfalls for SCNs. In case of the honeycomb pattern, there are many septa and the cystic locules are very tiny. In these patients, after intravenous contrast administration, the lesion, although it is cystic, the lesion may mimic a hypervascular pancreatic tumor and may be mistaken for PNET. This is a typical example. On T2 weighted image, you can see a bright cystic-looking lesion with a lot of septa inside. Pre-contrast and post-contrast. On the post-contrast, it looks like this is a hypervascular lesion, like it's PNET. I did this mistake, so I should mention about it, but it came out to be a microcystic SCN. Actually, in this patient, I believe EUS would help a lot to show the cystic nature. SPNs, solid pseudopapillary neoplasias, are typically daughter lesions. They are seen in young age and mostly females. They are mostly solitary. We won't see any ductal communication. Here, the cystic degeneration is due to necrosis or hemorrhage. And if there is hemorrhage inside the lesion, we are lucky because it will have a specific signal on MRI. Normally, cysts are dark on T1 and bright on T2. But if there is hemorrhage, it will be bright on T1 and dark on T2. Now, I will show you an example. Daughter lesion, young female patient, there is a big mass at the pancreatic head. In the central portion, there is a cystic component, and on T1, it is bright, and on T2, it is dark. It's typical for hemorrhage signal. And the solid components that enhance after contrast administration will be mostly located at the periphery in case of SPNs. Before switching on to mucinous subtype, I will mention about cystic PNETs. They are rare subtype of PNETs that are mostly located at the distal part of the pancreas. They have low but well-known malignant potential, so it is important to differentiate them from non-neoplastic cysts. And here, the main clue will be avidly enhancing rather thick wall of the lesion. I will show you a typical case. Middle-aged male patient, there's a cystic lesion at the tail of the pancreas, which is bright on T2 weighted images. Please concentrate on this image. On the post-contrast image, when you compare with the pre-contrast one, there is avid enhancement of the rather thick wall, which came out to be a cystic PNET after resection. Now, lastly, I wish to mention about mucinous cysts. Mucinous cystic neoplasias, MCNs, are typically mother lesions. Here, the demographic data helps us a lot because they're almost always seen in females, like my colleagues told you, because they have ovarian stroma. The most common location is the body and tail. They will have multiloculated, mostly they will be postilocular, different from microcystic SCNs. There will be few septa inside with larger locus. Contrast enhancing wall and smooth outer wall will help in the differential diagnosis. The clue is middle-aged female cystic mass in the distal part of the pancreas. There are some imaging features that suggest coexisting invasive carcinoma. Of course, we cannot be sure, but if the lesion is larger than 4 centimeters, if it has thick irregular wall and septa or nodularity inside, then these are signs of invasive carcinoma. Mother lesion, middle-aged female, there is a cystic lesion at the tail portion of the pancreas with a few septa inside. And after contrast administration, you can see outer smooth wall and contrast enhancement at the wall. This is not as much as a cystic PNET, but this is more pronounced than SCN. The last subtype I will mention about are the IPMNs. They are mucin-secreting epithelial neoplasms, and due to the secretion, one will see dilatation, mainly in the main pancreatic duct. At the time of diagnosis or during follow-up, they may be associated with hyperplasia, different grades of dysplasia, or even invasive carcinoma. They have 3 main subtypes according to morphology of ductal involvement. These are branch duct with the least risk of high-grade dysplasia and malignancy. And we have the main duct and mixed types. Here, radiologists should be aware of the field defect. If a patient has IPMN, there is increased risk of PDAC development in elsewhere in the pancreas. This is like a diseased pancreatic parenchyma, like HCC development in cirrhosis. So during evaluation and follow-up of IPMNs, we should not only concentrate on the IPMN lesion, we should carefully analyze all parts of the pancreas. During IPMN reporting, what are your expectations from us? First of all, of course, to identify IPMN and to define the morphology, because they have different prognosis and management. We need to comment about the risk of malignancy. For this, there are some guidelines. There are 5 major guidelines with minor differences in imaging criteria. In our center, we most commonly use the revised Fukuoka criteria. Branch duct IPMNs are typically seen as cluster of cysts. They look like bunch of grapes, and there will be ductal communication. Here, multiplicity is an important feature to be aware of, which helps us in the differential diagnosis with other subtypes. It has the least risk of malignancy. Let me show you a very typical case. There is a cystic lesion on coronal and axial T2 weighted images with septa inside. And on the MRCP, the ductal communication is very nicely shown. So this is a very straightforward diagnosis. There are no worrisome features or high-risk stigmata in this patient. Main duct IPMN or the mixed variants are characterized by dilatation of the pancreatic ducts, which may be diffuse or segmental, and one will see nodular structures, may see nodular structures inside the dilated duct, which may be mucin globes or mural nodules. How to differentiate? If these lesions enhance with contrast, they will be mural nodules, different from mucin globes, which won't enhance. Risk of malignancy is higher. Here, it is not difficult to put the diagnosis of IPMN, main duct mixed type. Here, the main challenge is to differentiate this entity from chronic pancreatitis, because they will both have parenchymal atrophy, they will have ductal dilatation. Of course, we need clinical correlation like alcohol consumption. Presence of calcifications or intraductal stones will favor the diagnosis of chronic pancreatitis. And also in chronic pancreatitis, when you compare with IPMN, the dilated duct will be more irregular, but this is not a rule. And we also know that both entities may coexist at the same time. So this makes things more complicated from radiologist's perspective. Here you can see a patient with mixed type IPMN. There is main ductal dilatation. It is more than 1 centimeter. So this is our first high-risk stigmata. There is a side branch IPMN, branch duct IPMN at the body portion. If we concentrate on this, on T2 weighted image, there are some papillary structures inside the side branch IPMN. And this is the pre and this is the post-contrast image. They are enhancing with contrast. And they are more than 5 millimeters. So this is the second high-risk stigmata. Patient had total pancreatectomy, which revealed mixed type IPMN with high-grade dysplasia and also papillary nodule. These are the revised Fukuoka criteria that we use in our center. I won't go into detail, you know better than me. Although not included in the guidelines, if there is dilatation at the dominant uncinate duct, we try to mention this in our reports because recent data have shown that this is an independent risk factor for coexisting high-grade dysplasia or invasive carcinoma. Before I conclude, I would like to briefly share with you preliminary results of our study. It was a thesis study. Patient cohort was 101 patients with pancreatic tumors. More than 90% of them were PDAC that were resected. I and one of my radiologist colleagues reviewed the CT and MRI images of all these patients in our PACS system. We map all the cysts we saw that is included in the pancreatic resection. Then, thanks to our pathologist colleagues, we have performed on-site radiology-pathologic correlation, and a total of 130 cysts in 101 patients were evaluated together. The rate of cyst detection was more than 50% in this series. Well, it is not surprising because these were patients with pancreatic tumors. The most common cyst subtype, as expected, was retention cysts and secondary ductal dilatations. Second was IPMNs. Rarely we saw SMCs, simple mucinocysts, scopes, pseudocysts, and cystic peanuts. The diagnostic accuracy of MRI was better than CT. The highest mean age was seen in IPMNs. On the other hand, the lowest mean age was in cystic peanuts. Among all the cysts, CT MRI, whatever is available, some of them were not optimal. We had 80% correct diagnosis and 11% wrong diagnosis when we compare it with pathology. IPMNs and SMCs were larger, retention cysts were smaller. Multiplicity was most common in IPMNs and retention cysts as expected. On the other hand, scopes, SMCs, and cystic peanuts were all solitary in all cases. An important percentage of patients were shown to have more than one cyst subtype with different pathologic diagnoses. Most common correct diagnoses were retention cysts and cystic peanut. On the other hand, due to the lack of unique imaging features, the most common wrong diagnoses were scopes, squamous cyst of the pancreas, and simple mucinous cysts. I think this point is very important. Cysts that tend to be associated, I mean adjacent or very close, with the primary tumor were, as expected, retention cysts all the times, but in 90% of cases, they related with SMCs. We tried to further investigate the imaging features of SMCs and scopes. The mean diameter was larger in SMCs. They rarely had septa, but scopes never had septa. SMCs were mostly in relation with the primary mass. Scopes had no contact with the primary mass. What changed after this thesis in my routine practice? Now, I more often diagnose retention cysts around the primary lesion, pancreatic lesion. I thought some of them were branch duct IPMNs, and these are termed as pseudo-IPMNs by Dr. Atsay et al. In one of the papers. Radiologists tend to misdiagnose retention cysts as branch duct IPMNs. Now I am more aware about the non-neoplastic cyst subtypes, and again I'm more aware about the possible paradigm shift in the SMC. It doesn't look like a simple cyst because in our series, in 33% of the patients, high-grade dysplasia was found in the SMC. I am now more alert about the newly appearing retention cysts because they may be preceding PDAC. I don't know the incidence, possibility, risk, but I know that I should be alert about it. An important percentage of patients had coexisting cysts with different pathologic diagnoses. So during evaluation of PCLs as radiologists, I believe it's important to map the lesions separately. And I believe, thanks to our pathologist colleagues, this was too much work. On-site radiology-pathology correlation was the best feedback for us, for a diagnostic radiologist. But still, we have a lot of way to go. There's still so much progress to make because some of the cyst subtypes have only very minor differentiating features. We should investigate further. Thank you very much.